Good morning, everyone, and welcome to day 2 of this 2022 Children's Week virtual conference. I'm Dr. Ruth Adewiya. I'm the Managing Director for the Center for Continuing Medical Education, and I am so pleased that you are able to join us for this morning's session. Just a quick, some housekeeping. One is that throughout the session, our speakers are asking you to ask questions using the Q&A functionality on your Zoom. So at the very bottom of your Zoom screen, you'll see a Q&A button there. So all throughout, when you have questions, go ahead and post them in there, and there'll be dedicated time during the session for them to address those questions. I also want to let you know that you have the option of claiming CME for the activity if you'd like. There's nothing you have to do at this point. An email will be sent to you tomorrow with instructions on how you can claim CME for this session. Oops, I have the wrong. So without any further ado, I would like to introduce you to our two presenters for this session. Dr. Nicole Wing is a clinical assistant professor of pediatrics, neonatal and developmental medicine. She earned her degree at the University of Northern Texas College of Osteopathic Medicine, completing her residency here at the Lucile Packard Children's Hospital, Stanford. Joining her today is Dr. Nivedita Srinivas, who is a clinical associate professor and board certified in both pediatrics and pediatric infectious diseases. She earned her degree at UCSF, her residency at Washington Children's Hospital and Regional Medical Center, and her pediatric infectious disease fellowship at Stanford. I'd like to thank them both for joining us for this session, and I'll turn it over to them.
Thank you so much, Ruth, and good morning, everyone. Welcome to the first session of the day. We know it's early this morning. Dr. Wang will be pulling up the slides. We're delighted to have you. Please enter any questions you may have in the chat, and we will respond to them as we go. We'll also have time at the end of this session for questions. So we'll be discussing congenital CMV infections and the implications for hearing morbidity or hearing loss in children during today's session. I'm again Nita Srinivas, and my co-presenter is Dr. Nicole Wing. We have no financial disclosures or conflicts of interest. These are the objectives we hope to cover today. First, we'll discuss the risk factors, signs, and symptoms associated with congenital CMV infection. We hope to then examine CMV-related hearing loss and how it relates to long-term surveillance and treatment options for this population of children. Third, we'll compare and contrast the different types of laboratory testing available for congenital CMV infection diagnosis. And then finally, we'll review the evidence related to CCNV hearing-targeted screening and the utility of screening specifically in the newborn nursery. We will refer to congenital CMV henceforth as Ccnv. There will be some audience polling options. If you are not familiar, there is a polling feature within Zoom. The questions will appear as a pop-up, and individuals will have 20 seconds to respond. You'll select one response from the multiple choice options displayed, and after we've had that time lapse, we'll then display the final answer to everyone. Feel free to ask for help in the chat or by raising your hand if you have any issues. So our first question for the audience, because we are a large group and we'd like to learn about each of you and who our audience is today, is in what clinical setting do you currently practice? Outpatient, inpatient, a combination of the two, or perhaps you are not actively involved in clinical care for that fourth option? We'll give everyone time to select an option, and then we'll display the results. Fantastic. We have a very diverse audience with a range of clinical practice backgrounds. A mixture of both outpatient and inpatient, and then a quarter of our participants are not actively involved in clinical care. Second question. How would you rate your knowledge of congenital CMV as it relates to hearing loss specifically? First option is quite knowledgeable and up to date on evidence-based practices. Second option is somewhat knowledgeable, though not quite up to date. Third is seeking more information, and that's why you're here today, and we welcome you. And four is a tongue-in-cheek option, what is CMV? But if you've never heard of CMV, feel free to indicate that option. We're waiting for the results to come in. The majority have said that they're somewhat knowledgeable, but not quite up to date on evidence-based practices. A third of our audience have said not quite knowledgeable and seek more information, and then 10% are quite knowledgeable and up to date on evidence-based practices. Thank you. And we have a final audience poll question. We were interested before we dive into the presentation to understand what sentiments might be around universal congenital CMV screening, which we'll talk about more throughout our presentation. Do you think universal congenital CMV screening should be implemented? And the options are yes, an emphatic yes. Second is no, it should be done only through hearing targeted screening, which we'll also talk more about today. Third is no screening at all should be performed. And the fourth option is unsure. And we have our results with 44% of participants saying that yes, universal congenital CMV screening should be implemented. The next largest group is that CMV screening should be done through hearing targeted screening. And then a fifth of participants said unsure how to respond. Thank you very much for completing those poll questions for us. That gives us a sense of who each of you are and what knowledge you're coming into this presentation with. Okay, one more poll question before we dive into the actual talk. We have a patient case. You are an outpatient pediatric healthcare provider, and your first clinic patient of the day is a roughly 2-week-old newborn who was born at term and is otherwise healthy and presenting for a well child visit. Just have the slides pull back up. There we go. The newborn, had an uncomplicated postnatal course aside from 2 failed newborn hearing screens after birth. He has been referred to audiology and will be seen at 1 month of age. You recall that there is an association between CMV infection and hearing loss. Which of the following is associated with hearing loss? The first option is postnatally or acquired CMV infection. The second is congenital CMV infection. Third option is both A and B, both postnatal and congenital. And then fourth is none of the above. Just waiting for responses to come in, and then we'll display the results shortly. There we go. So yes, the correct answer is B, congenital CMV infection, though there is emerging evidence that even children who have postnatally acquired CMV infection are at risk for hearing loss. The data has not been fully defined, but particularly those that are preterm or very low birth weight are at risk. So technically the answer should be both A and B, but we most commonly think of hearing loss being associated with congenital CMV infection. Thank you for your responses. And with that, we'll begin the presentation. A little bit of background about CMV infection in general. CMV belongs to the herpes viridae family. It is a double-stranded DNA virus, and it has latency like many of the other herpes viruses like EBV and HSV. The viral DNA persists in leukocytes, and with the reactivation of the virus can have shedding in many different bodily secretions, including saliva. Transmission is human to human and occurs through direct contact with bodily fluids. There are no known reservoirs in animals for human CMV, but there are other strains in animals that affect those animal species alone. They are not transmissible to humans and vice versa. The clinical manifestations really depend on the host immune status and can range on one end from asymptomatic infection, particularly in those who are considered immunocompetent or who have had a past CMV infection and are infected with a new strain, to a mononucleosis-like illness, which is what we most typically characterize acute CMV with. A febrile illness with lymphadenopathy plus or minus a rash. And then on the other extreme, and particularly those who have immunodeficiency, it can be associated with organ system dysfunction. For pregnant women, which is a group that is at high risk of primary infection with implications for the developing fetus, the biggest risk factor for infection, if they've previously not been infected, is close contact with young children, particularly children who may be in daycare. And this is an underappreciated opportunity for education of women who are childbearing age or who are pregnant. There have been studies done examining interventions, educational interventions on acquisition of primary CMV infection during pregnancy, and they've actually shown to be beneficial in reducing rates of acquired CMV in pregnant women. However, most healthcare providers who might be interacting with pregnant women over the course of their care are themselves unaware of the risk of CMV, and that gap is where I think there are opportunities for reducing the burden of CMV on neonates in particular. The seroprevalence among women of reproductive age actually varies significantly across the world. Here in North America, the range is about in the 60 to 80%. Globally, and particularly in the developing countries, that rate is much higher, closer to 85%. Intrauterine transmission is more likely from primary maternal infection versus non-primary infection. So women who acquire CMV for the first time during pregnancy have the highest likelihood of transmitting CMV to their newborn, to their fetus. CMV is considered one of the torch infections. That's not to say that women who are previously seropositive cannot transmit from reactivation of CMV or from infection with a different strain. It's just that the likelihood of transmission in those scenarios is lower due to the presence of seroprotection from the mother. A little bit of background about congenital CMV. The prevalence of congenital CMV mirrors the seroprevalence in mothers around the world, higher in the developing countries, as you can see, 1 to 5%, depending on the study and the part of the world, lower in developing countries, roughly 0.6 to 0.7%, including here in the United States. That translates to a burden in the US of 40,000 new cases of congenital CMV per year. Of course, all of those are not clinically apparent at the time of birth, and that is one of the key takeaway points from this talk. The risk of transmission, again, varies depending on whether it is a primary infection or reactivation. 40% with primary infection, versus roughly 1% with non-primary infection. The vertical transmission can actually happen at distinct periods. So it can happen either in utero through transplacental acquisition, and we think that this occurs through viremia. So the mother becomes viremic with CMV, and then there's transplacental passage of the virus to the fetus. It can happen at the time of birth, or it can occur postnatally via human milk, which would be postnatally acquired congenital CMV. Another important takeaway point is that the incubation period for CMV is on the longer side. It's roughly 3 weeks. And that will highlight one of the other points we hope to make through this presentation, which is that a diagnosis of congenital CMV, in order to define it as congenital, needs to be made within 21 days of life. So we talked about the transmission during pregnancy, and about 40,000 babies are born in the US annually with CMV, and how only a minority of them are apparent at birth, so that the actual percentage breakdown is roughly 10% will be symptomatic at birth, and we'll talk about symptoms shortly. And of the 10% who are symptomatic, 40% of them will go on to have permanent sequelae, and of the permanent sequelae, hearing loss, sensory neural hearing loss is the most predominant. So the burden of hearing morbidity and hearing loss is significant. Here are some of the signs of congenital CMV infection. Again, it is one of the TORCH infections, which is an acronym for some of the common congenitally acquired infections. The C in TORCH is for CMV or cytomegalovirus. And this figure displays the myriad of congenital signs in the 10% of babies that are born symptomatic with congenital CMV infection. We'll start in the upper right-hand corner and then move clockwise. Cns manifestations are variable and range are seen in 30 to 70% of babies. As you can see, there's a host of presentations in CNS, most of which are only identified if imaging is pursued. The one that can be clinically apparent without imaging, however, is microcephaly. And this is an important component of the physical exam to pay attention to in the examination of newborn babies, is looking at the head circumference and the head circumference percentile for gestational age. The other findings include ventriculomegaly. Intracerebral calcifications are the most common manifestations seen on imaging amongst those that are both symptomatic as well as asymptomatic, and seen in as many as 60 to 70% of neonates with CCMV. The calcifications tend to be periventricular, specifically distinguishing it from toxoplasmosis, where the calcifications tend to be more scattered. And then cortical or cerebral malformations like polymicrogyria are also seen. Going with the CNS manifestations of congenital CMV are sensory neural hearing loss. It's seen in as many as 35% of neonates with CCMV, both symptomatic and asymptomatic. Again, this is not a clinically apparent finding and is usually identified on universal newborn auditory screening. Although, as we'll point out later, many of these babies are born with normal hearing and actually progress to developing hearing loss as they grow older, typically within the first 3 years of life. The sensory neural hearing loss is thought to be due to inflammatory labyrinthitis caused by the viremia from infection. Other manifestations include hematologic abnormalities, specifically thrombocytopenia, seen in as many as 50% of infants. IUGR has been described also commonly in about 40%. However, IUGR or SGA, small for gestational age, is not by itself clinical sign associated with CMV. It's typically associated with many of the other findings that we see here. So SGA alone is not an indication for testing for congenital CMV infection. Other manifestations, which you see here on the left, include impacts on the hematopoietic system, so hepatomegaly, liver elevations, splenomegaly, and then chorioretinitis. The evaluation, if you have a neonate that you suspect may have CMV and is born symptomatic, include the test outlined here. It typically includes laboratory studies of the blood, including a CBC, chemistries, including liver function tests and bilirubin levels, brain imaging with ultrasound usually being first line because of the ease of obtaining it. And that's typically used for developmental prognostication to understand how much CNS involvement there actually is, and that might have implications for how frequently this baby is monitored, high-risk infant follow-up, et cetera. Ophthalmologic evaluation is also very important to evaluate for chorioretinitis, again, implications for eye disease and morbidity as it relates to sight. And then finally, the complete diagnostic audiology assessment, so that we all know that universal hearing screening is typically done in the newborn nursery. But if there is clinical suspicion for congenital CMV infection, it's very important that these babies have a formal diagnostic audiologic evaluation within the first 3 months of life. Many subspecialists are typically involved as part of this evaluation, and amongst those are infectious diseases specialists who can help sort of synthesize this information, including physical exam findings, laboratory findings, the clinical history, maternal history, and then use that information to determine if antiviral treatment is indicated. And we'll talk more about antiviral treatment options later. Neonatal congenital CMV infection is categorized in 4 different ways, and we thought it would be important to highlight some of that terminology here. The top 2 categories, which we'll speak to first, are asymptomatic infection. Asymptomatic CMV, the very first category, is the baby that has no apparent physical exam abnormalities and normal hearing on that initial hearing screen. There's a subset of asymptomatic CMV, however, which is underappreciated. And that is the child or the newborn that has no apparent physical exam abnormalities, but has an abnormal hearing screen. They have none of the other clinical signs that we displayed on that figure earlier. None of the thrombocytopenia, the rash, the petechiae that can be seen as a result of the thrombocytopenia, and the microcephaly, but they may have a failed hearing screen. And what we'll highlight later in this presentation is that a failed hearing screen should be a signal for us to think about congenital CMV infection and make sure that those babies have appropriate audiologic follow-up and additional testing. And then the last 2 categories are mild symptomatic congenital CMV infections. So these 2 are the symptomatic categories. So there's mild and then moderate to severe. Mild is usually transient manifestations of congenital CMV infection. They may have apparent thrombocytopenia or a rash, and then mildly elevated transaminitis, but with follow-up, those manifestations usually resolve. And then moderate to severe symptomatic congenital CMV infection carries a significant degree of morbidity as well as mortality. These are the babies that are more typically infected in utero in the first trimester or early on in pregnancy, and mother-acquired primary infection during the pregnancy early on. And the manifestations include all of the things that we've already talked about. They more typically also have significant CNS involvement, including chorioretinitis, and then sensory neural hearing loss as well. We'll move to talking next about Ccnv-related sensory neural hearing loss, which is really the crux of this presentation. Ccnv-related sensory neural hearing loss is the most common non-genetic cause of permanent childhood hearing loss. Genetic causes being first. Of the non-genetic causes, CMV is the most common. There have been different studies modeling what the burden of Ccnv-related hearing loss is amongst all hearing-related morbidity, and it's estimated to be roughly 20% of all hearing loss. in the United States. The frequency of sensorineural hearing loss, however, really depends on whether the newborn is presenting as asymptomatic or symptomatic. So symptomatic newborns, the burden of hearing loss is higher, which is not surprising. These are babies, again, that probably had a higher degree of viremia in utero, and they were infected more early on in the pregnancy during their development, more likely had moms that were primary infection during pregnancy. So those babies, 40 to 60% of the symptomatic newborns will have sensorineural hearing loss versus the asymptomatic newborns. So these are the babies that are born who clinically do not have any apparent signs of congenital CMV infection. Roughly 10 to 15% of those babies will have sensorineural hearing loss apparent either in the newborn period or apparent and subsequent hearing screening. So about half of them will actually only become apparent later in life. Symptomatic children, however, have a greater degree of severity and an earlier progression of their hearing loss. And we have a table in a future slide that highlights that further. So this is the slide I was referring to. This is data from a systematic review of 37 studies examining CCNV and sensorineural hearing loss published in Pediatrics in 2014. The blue shaded box represents the subset of infants who were symptomatic at birth, and the box shaded in green are the children who were asymptomatic at birth. And what you could see is that the proportion of bilateral hearing loss is higher in the symptomatic, the babies that are symptomatic at birth. However, unilateral hearing loss is more common in those that are asymptomatic at birth. And then if you can click to the next slide, please. The burden of delayed hearing loss and progressive hearing loss is also fairly significant across both groups. As you can see, 18% delayed hearing loss in the symptomatic group, 9%, which is lower in the asymptomatic group, but still significant, and then progressive hearing loss, roughly 20% in both groups, highlighting the importance of ongoing close audiologic follow-up in these babies. The management of sensorineural hearing loss due to congenital CMV can be institution specific. However, we have some general guidelines here with input from our ENT colleagues at Lucile Packard. If the initial diagnostic hearing evaluation is normal, so this is a baby who has had an initial newborn hearing screen in the newborn period that is flagged as abnormal, is seen for a formal audiologic follow-up. That normal hearing screen is typically reassuring and only needs to be repeated annually until the child is 3 years of age. And these, again, are for children who are tested for congenital CMV based on that initial failed hearing test and are identified as being positive. They just need annual screening until age 3 years if their first diagnostic hearing test is normal. However, if the initial diagnostic hearing test or confirmatory test is abnormal, they should be followed more closely. Typically, it includes referral for hearing rehabilitation and speech therapy to improve or maximize hearing outcomes and to prevent or mitigate speech or language delays. And then, of course, cochlear implantation is considered for those with severe to profound sensorineural hearing loss and deafness. Unilateral sensorineural hearing loss with CCNV is also seen, as we know, and that can also be an indication for cochlear implantation to try to preserve hearing in that ear, since there is a risk of progression to hearing loss in the contralateral ear over time as well. A little bit about antiviral treatment in congenital CMV. So the initial studies were done with IV ganciclovir, looking at 6 weeks of IV ganciclovir, and the outcomes were related to progression of hearing loss, as well as neurodevelopmental outcomes. And so those children were hospitalized for 6 weeks with a PICC line and receiving ganciclovir per the study protocol. More recently, we have shifted to the use of oral valganciclovir with a treatment duration of 6 months for infants with moderate to severe CMV, which is the study population that these drugs were initially studied in. And again, both have been shown to improve audiologic and neurodevelopmental outcomes as far out as 2 years of age. There remain uncertainties about how to manage antiviral treatment for those children who have mild symptomatic CCNV or who are asymptomatic with isolated sensory neural hearing loss. It's typically pursued on a case-by-case basis in shared decision-making with caregivers or parents, and a discussion of the relative risks or toxicities of the antiviral therapy, as well as the potential benefits of treatment. There is a multi-center study being pursued currently with Stanford being one of the sites, examining outcomes of treatments with isolated sensory neural hearing loss. However, they have had difficulty with recruitment due to low numbers. Important toxicities with both ganciclovir and valganciclovir to be aware of are listed here, with neutropenia being the most common, and it's been seen in as many as 50% of study participants with both drugs. Other side effects include transaminitis, other hematologic abnormalities, specifically anemia, renal insufficiency, and then there is the potential for teratogenicity as well. So how do we screen? And this is a big source of controversy and ongoing need for further study. There are two different approaches for screening. And so this is specifically looking at those babies that are not symptomatic at birth. How do we capture the burden of congenital CMV, knowing that only 10% of infants are symptomatic at birth, and also knowing that many will have normal hearing screens initially and progression of their hearing loss or hearing disability over time. And so there are two primary screening modalities. One is universal screening, and the other is hearing targeted screening. Hearing targeted screening can be performed inpatient or outpatient. The flag here is that baby that is asymptomatic but fails their initial hearing screen in the birth hospitalization. So that's what hearing targeted screening is referring to, is that specific subset of patients without clinically apparent disease, asymptomatic, and failed newborn hearing screen. The testing is usually pursued via PCR testing of either the saliva or the urine. And this can be done, again, inpatient or outpatient, although pursuing the testing inpatient is typically associated with higher compliance with actually completing the testing. Utah was the first state to implement a screening approach, with which Dr. Wing will highlight later. And then here in California, of the institutions that we know of, here's a list of those institutions that perform some form of screening. Most of them are performing hearing targeted screening. That includes several Kaiser centers, our center, Stanford Children's at the Lucile Packard campus, UC San Diego, and UCSF. There is a National CMV Foundation. It's an advocacy group that advocates for screening efforts for congenital CMV infection. And this map, which is current as of this year, or sorry, as of 2020, examines congenital CMV legislation in the United States, with the different shades representing the different stages of whether laws were passed or proposed. California had legislation for hearing targeted screening proposed 2 years ago, which did not pass. Back to our patient. So if you recall, this is the 2-week-old newborn male who is otherwise healthy and appears well, does not have any clinical stigmata of congenital CMV infection, had 2 failed newborn hearing screens at birth, and is going to have a formal diagnostic audiologic evaluation at 1 month. And you're thinking, okay, I remember that there's an association between CMV and hearing loss. This baby has failed 2 hearing screens in the newborn period. What's the next best course of action for this patient? First option is nothing, wait for the visit with audiology. Second is obtain laboratory studies, including CNVC and chemistry. 3 is call the hospital and request that CNV PCR be run on the dried blood spot that was obtained as part of the newborn screen. The fourth option is obtain CNV DNA PCR on a urine sample. And fifth is refer to ENT. You have 20 seconds to select one response, and then we'll display the results. Okay, here are the results. We have a nice variation in how people would respond. 38%, so most people in this group would proceed by obtaining a CMV DNA PCR on a urine sample. The next most common response was try to obtain the dried blood spot and have a CMV PCR run on that specimen from the newborn hospitalization. And then the next most frequent response was try to get more information, including a CBC and chemistry. Thank you for your responses. The correct response is that it would be best to proceed by obtaining a CMV DNA PCR from the urine. Time is of the essence here, with this child now being 16 days of age. And that window, if you recall, for a congenital CMV diagnosis is within the first 3 weeks of life, or 21 days of age. Given sometimes the difficulty for parents of obtaining the urine specimen, dropping it off at the lab, we would advocate for getting the urine study done as soon as possible, not getting the other serum studies, including CBC or chemistry. And similarly, the dried blood spot, while in theory would be a good approach, the sensitivity and specificity of that diagnostic modality is actually not high enough to proceed with that option. It's also very difficult in terms of the logistics of getting that testing done. Not every hospital center is a site that can actually process a dried blood spot. Here on the West Coast, we've typically sent our dried blood spot testing for babies that might present later, and there's a question and the parents really want to know. We end up sending our testing to the University of Washington or Seattle Children's. We want to highlight these Ccnv consensus guidelines, which were published in The Lancet in 2017 from a host of authors, all listed here from across the country, who are congenital CMV experts. This is an excellent resource if you are seeking to learn more about congenital CMV infections, diagnosis and management. Again, though, in the key findings and recommendations from this panel of experts, they highlight the importance of performing the appropriate testing within the first 3 weeks of life. They highlight saliva as the preferred sample. It is what we use here at Lucile Packard as well, due to ease of obtaining the results, the relatively high sensitivity and specificity. But if you are thinking of congenital CMV infection in the differential, particularly if you have a baby with a failed newborn hearing test, try to get that testing done as soon as possible within 21 days of life specifically. We wanted to share the different testing modalities. So prior to PCR testing becoming more widely available, the gold standard for CMV diagnosis and congenital CMV diagnosis was a viral culture, which was incredibly labor intensive and also very time intensive. So you'd be waiting for the cell culture to show a cytopathic effect to make the confirmation of the diagnosis. Now with the advent and availability of PCR testing, this has become the gold standard. Urine CMV specifically has shifted to the gold standard with a very high sensitivity and specificity, as you see listed here. However, particularly in the newborn period, when newborns are urinating relatively infrequently, it can be very difficult to get the urine sample prior to the baby being discharged home. For that reason, many institutions, particularly those that are trying to complete the screening for hearing targeted screening during the birth hospitalization, have shifted to a saliva-based platform, which also has very high sensitivity and specificity. We have most frequently seen false positives from mothers who are breastfeeding and who have reactivated their CMV. They're seropositive mothers. They've reactivated CMV and perinatally, and they are shedding CMV in their breast milk. So hence the importance of spacing apart any breastfeeding from obtaining of the saliva sample as much as possible, and at least 2 hours apart is what we recommend. The dry blood spot sensitivity, as you see here, is quite low, which is why it is not typically pursued as a first testing strategy, but can be used in scenarios where there's really a question of, does this baby have congenital CMV infection, and the time period for congenital diagnosis has passed. With that, I will hand it off to Dr. Wing, who will continue with the rest of the presentation.
Okay, thank you, Nita, for that review. So for the next part of our talk, we'll be reviewing a few studies pertaining to hearing-targeted congenital CMV screening in newborns. So the first study we'll be reviewing is the CHIME study, which was a large multi-center study that looked at the effectiveness of hearing-targeted screening in identifying infants with CMV-related hearing loss. So in this study, 100,000 infants born over a 5-year period all received a newborn hearing screen and were also screened for CMV. Infants were found to be CMV positive, then underwent further audiologic evaluation at 3 to 8 weeks. This first chart shows the results. So again, there were 100,000 infants during the study period who were all tested for CMV. Of those, 449 infants, which represents 0.4%, were found to be CMV positive. And of those infants found to be CMV positive, 31 referred on the hearing screen, which resulted in a referral rate of 7%. This was compared to CMV negative infants who had a referral rate of 0.9%. So this data showed CMV positive infants were significantly more likely to fail their newborn hearing screen compared to CMV negative infants. This next chart looks specifically at the hearing screening results of CMV positive infants. There were 443 CMV positive infants who underwent a hearing screen. Of those, 35 were found to have hearing loss. And interestingly, of the 35, 15 had actually passed the initial hearing screen. So in their study population, they found that 43% of CMV positive infants with hearing loss would have been missed with hearing targeted screening alone. So their study showed that, again, CMV positive infants do have a significantly higher referral rate as compared to CMV negative infants, which shows that targeted screening can be an effective approach for identifying those infants with CMV-related hearing loss at birth. However, this targeted approach misses CMV positive infants who are at risk for late onset hearing loss, which is likely due to the combination of both the progressive and late onset nature of CMV-related hearing loss, as well as potentially the poor sensitivity of the newborn hearing screen. And this is what makes screening and detecting infants with CMV-related hearing loss so challenging. The second study we'll be reviewing are the results from Utah's hearing-targeted CMV screening program. So as Nita mentioned, Utah was the first state to implement hearing-targeted screening for CMV, and per their protocol, infants were eligible to be screened if they failed both their inpatient and return outpatient screening, or if they failed their first hearing screening if it occurred after age 14 days. And that cutoff was to ensure that infants were tested within that 21-day window. So as you can see, their screening protocol relied heavily on outpatient follow-up. During the study period, which in this paper was 24 months after implementation of Utah's legislation, there were roughly 103,000 infants born. Of those infants, 509 never passed a newborn hearing screen, were asymptomatic, and were therefore eligible for CMV screening. Of the 509, only 234, which represents roughly 46% of eligible infants, were tested for CMV within 21 days of birth. And of those 234 infants, 14 were found to be CMV positive, and of those 14, 6 were found to have hearing loss. So this study had a few interesting findings. One was suboptimal compliance with state-mandated CMV testing. As I mentioned in the previous slide, only 46% of eligible infants were screened for CMV. One of the factors that could have affected their compliance was that their screening protocol, again, relied heavily on outpatient follow-up. And as many of us who practice clinically have probably experienced, coordinating outpatient follow-up testing in a timely newborn can be challenging, particularly for congenital CMV, which has that narrow diagnostic window of 21 days. The authors additionally looked at sociodemographic factors associated with compliance and found that lower maternal education and non-hospital births were associated with lower odds of CMV screening. The second interesting finding was the prevalence in the study of congenital CCMV-related hearing loss that was detected. So assuming a prevalence of 0.5% for congenital CMV and extrapolating from the results of the CHIME study, we would expect that out of a birth population of 100,000 infants, they would have identified 20 to 30 infants with CCMV-related hearing loss. However, only 6 infants were identified, which is likely due to the inability of targeted screening to identify CMV-positive infants at risk for delayed onset hearing loss. The next study we'll be reviewing are the results from the first year of the Yale New Haven Health System's hearing targeted screening program. So Connecticut is another state that recently implemented hearing targeted screening. Their protocol differed from Utah's in that infants were screened for congenital CMV as an inpatient. So any infant that failed their newborn hearing screen was tested for CMV using saliva CMV PCR, and any infant that had a positive saliva CMV PCR then had a urine CMV PCR test sent for confirmation. During the study period, there were roughly 10,000 births. Of those, 171 infants failed a newborn screen, and all 171 infants were tested for CMV. 3 infants had a positive saliva CMV PCR, and of those, only 1 was confirmed to have congenital CMV. For the other infants, 1 was a false positive, as they did have confirmatory urine testing sent that was negative, and the third did not have confirmatory urine testing sent until 10 weeks, which is outside the diagnostic window for congenital CMV of 21 days. So we're unable to distinguish for that infant whether it was congenital or postnatally acquired infection. So in this study, they had excellent compliance with inpatient testing. Again, 100% of infants who were eligible to be screened were tested for CMV, which is likely attributed to their inpatient screening protocol. The authors in this study anticipated that they would identify 4 to 9 infants with CCMV-related hearing loss. However, they only identified 1 infant out of a birth population of approximately 10,000. So both the Yale and the Utah data both showed overall a low yield for detecting CCMV-related hearing loss using hearing targeted screening. And just to switch gears, I wanted to briefly review our own hearing targeted screening program at Stanford Children's that was implemented in December 2018. So to implement this screening program required a modification to our existing method for CCMV testing. So prior urine CMV DNA PCR testing was the main form of testing available for neonates at our institution. And as part of the screening program, we implemented saliva CMV PCR testing, as it is a quicker, more convenient form of testing and also a less expensive test to run. We took a multidisciplinary approach to implementing this screening program, which included representatives from Peds ID, ENT, audiology, newborn nursery, and our intermediate care nursery. As part of our QI work, we looked at the following metrics: the percentage of infants in Well Baby Nursery who received CCMV screening during the study period, the percentage of asymptomatic CCMV positive infants with hearing loss who would have been missed without a screening program, as well as the percentage of false positives. So implementing this screening program also required a modification to our existing workflow for algo referrals in our newborn nursery. So similar to other nurseries around the country, at baseline, all infants undergo an algo prior to discharge. If the initial algo is referred, a repeat algo is performed prior to discharge, and if the infant refers on the algo a second time, the infant is then referred to audiology for outpatient follow-up. As part of our screening program, if an infant refers on the second inpatient algo, albeit and that would be either unilateral or bilateral, the newborn hearing screener who performs the algo notifies the infant's bedside nurse. The infant's bedside nurse then talks with the family and obtains a saliva CMV PCR. And for that portion, we did provide the bedside nurses a congenital CMV educational handout for parents and for the nurses as well. The audiologist who at baseline reviews the chart of every infant who has an algo obtained at our institution added an additional step of checking each infant to see if the saliva CMV testing was sent. And if sent, she would follow each test until it resulted. If the saliva CMV test was positive, she would then notify a physician member of the multidisciplinary team. And then this physician member would then reach out to the infant's PCP to help coordinate outpatient urine CMV testing before the infant turned 21 days old. So as you can see, this protocol was nursing driven and also relied heavily on our audiologist and the infant's PCP for timely follow-up. These are the results from the first year following implementation of our hearing target screening program. So during the study period, there were roughly 4,400 births, of which 3,861 infants were discharged from Well Baby Nursery. Of those, 168 infants referred on the algo, and that's either a unilateral or a bilateral refer, and were therefore eligible for CMV testing. Of the 168 eligible infants, 154 were tested for CMV, of which 3 had a positive saliva CMV PCR. And of note, those were all false positives. All 3 infants had confirmatory urine testing that was negative for CMV, and all of those tests for confirmatory urine testing were sent within 21 days of age. In regards to our metrics, 91.6% of eligible infants screened for congenital CMV were screened for congenital CMV using saliva CMV PCR. We detected 0 cases of congenital CMV related hearing loss, and 2% of infants had a false positive result. So similar to the studies that we reviewed so far, our data also shows that hearing targeted screening in a high volume, high turnover setting, such as the newborn nursery, is feasible. However, we did have the unintended consequence of 3 false positives as we were working out the kinks in implementing saliva CMV PCR testing. So initially, we had educated our nurses to wait 30 minutes from the time of breastfeeding to the time of collecting the saliva sample. However, practically speaking, it should have been 60 minutes. After we changed that collection time to 60 minutes, we had no further false positives. But again, the lesson that we learned here was to practice caution around implementation of a novel screening test, which in our case was the saliva CMV test. So the data that we reviewed so far has showed that the overall yield of targeted screening is low. Advocates for targeted screening argue that although the yield is low, at least it's a starting point for identifying infants with congenital CMV-related hearing loss. Studies have shown that early identification and intervention for infants with hearing loss improves long-term developmental outcomes. Those who argue against targeted screening counter that without a proven and effective treatment, screening does not provide an additional benefit and may instead increase testing and parental anxiety. Another important factor to consider in this debate, of course, is the cost effectiveness of screening, which we'll look at in the next study that we'll be reviewing. So to answer this question of cost effectiveness of screening, Gant et al. Performed an analysis for both universal and hearing targeted CMV screening. They made several assumptions when creating their models. They assumed a prevalence of 0.5% of congenital CMV at birth, and that was extrapolated from the CHIMES data. They assumed a referral rate of 1.5%, of which 10% would have confirmed hearing loss, and they assumed a 12% reduction in cost due to earlier identification of hearing loss. This first graph shows the cost to identify 1 case of congenital CMV and 1 case of congenital CMV-related hearing loss using both targeted and universal screening. So assuming a cost of about $10 per test, they estimated the cost to identify 1 case of CCMV hearing loss utilizing targeted screening was $975 versus $27,000 with universal screening. The cost to identify 1 case of congenital CMV was $566 versus $2,000 for universal screening. So as you can see, universal screening was associated with a higher cost as compared to targeted screening, which is what we would expect, given the higher number of infants that would be screened. So with targeted screening, if we assume a referral rate of 1.5%, then roughly 60,000 newborns per year would be screened, as opposed to universal screening, which would involve screening roughly 4 million infants per year. The next two charts that we'll look at the net cost or savings per newborn for both universal and targeted screening. So the authors compared the net cost savings under the assumption of treatment versus no treatment. And treatment here is referring to the use of valganciclovir for both symptomatic and asymptomatic CMV positive infants with hearing loss. So when creating these models, they assumed that valganciclovir would be an effective treatment that would also provide long-term benefits in both subsets of infants. However, unfortunately, we do not yet have direct evidence that valganciclovir is effective in asymptomatic CMV positive infants with isolated hearing loss, which is something to keep in mind as we interpret these models. So this first model excluded the loss of productivity cost assumed to be associated with hearing loss. And as you can see, universal screening resulted in a net cost of $6 under the assumption of treatment versus $14 under the assumption of no treatment. However, targeted screening was associated with a net savings of $4 only under the assumption of treatment. Again, only under the assumption that valganciclovir is an effective treatment for both symptomatic and asymptomatic CMV positive infants with hearing loss. Under the assumption of no treatment, this model showed a net cost of $2 per newborn. So I know it's a lot of numbers, but in summary, in this model, only targeted screening was associated with net savings under the assumption of treatment. This next model included loss of productivity costs. In this model, the authors showed that both universal and targeted screening were most cost-effective under the assumption of treatment, with universal screening showing an overall larger net savings. Under the assumption of no treatment, universal screening was associated with a net savings of $1.67, whereas targeted screening was associated with a net cost of $1.80 per newborn. So in this study, the authors showed that universal and targeted screening are cost-effective under a wide range of assumptions, specifically when the loss of productivity costs related to hearing loss are included, and when there is an effective antiviral treatment for both symptomatic and asymptomatic infants with hearing loss. Under the assumption of no treatment, targeted screening is associated with a net cost, albeit a small cost of roughly $2 per newborn, and also involves testing fewer newborns. However, as we know, although very important, cost is not the only factor to consider when deciding whether or not to implement a screening program. The other factor that's very important in this case is the potential psychosocial impact of screening, particularly for disease in which the majority of infants will have no symptoms or sequelae. To examine parental attitudes towards newborn screening for CMV infection, Din et al. Surveyed parents in regards to their attitudes towards newborn screening for CMV infection. Responses were obtained from 3,900 participants as part of the 2009 Health Styles Survey, which is a national mail survey conducted by CDC. And the survey was sent to a random sample of respondents that was designed to be similar to the general US adult population according to gender, age, race, ethnicity, and household income. Participants were asked to respond to 5 statements in regards to testing of newborns for CMV infection. Responses were then dichotomized to strongly or somewhat disagree versus strongly or somewhat agree. Data was then analyzed using a 2-step cluster analysis. Among all the respondents, the vast majority, greater than or equal to 84%, strongly or somewhat agreed with the following statements: that they would want to have their baby tested for CMV even if my doctor or hospital didn't do it routinely. I would want to know if my child had CMV even if he or she never develops problems, and I would be willing to pay $20 to have my baby tested for CMV. So in this particular group that was surveyed, attitudes were generally favorable, with the vast majority of participants saying that they would want their child to be tested, even if there were no problems that developed and if they had to pay $20 per test in order for their child to be tested. Most parents also considered the potential costs, worry, and anxiety associated with newborn screening for CMV to be acceptable. So now that we reviewed a bit of the data, I wanted to summarize the pros and cons of both hearing targeted and universal screening, as there continues to be this ongoing debate as to which method of screening should be implemented. So the pros of hearing targeted screening is that it identifies those infants at risk for CMV-related hearing loss at birth, which is important as early intervention and monitoring have both been shown to improve developmental outcomes. Additionally, cost-effective analysis has shown a net cost benefit, but that again is only under the assumption that valganciclovir is an effective treatment for asymptomatic CMV positive infants with isolated hearing loss. Cons are that it fails to identify those infants with late onset CMV-related hearing loss, and as the CHIME study showed us, that can be up to 43% of infants that have late onset CMV-related hearing loss. Additionally, confirmatory testing for congenital CMV is a challenge due to the narrow diagnostic window of 21 days. And as we've seen in the Utah study, outpatient compliance can be low. We do not yet have direct evidence that valganciclovir is effective in treating asymptomatic CMV positive infants with isolated hearing loss. And we additionally lack more data on the psychosocial outcomes of screening for CMV, as well as the acceptability of screening by healthcare providers. Now switching gears and looking at universal screening. The pros to screening include the ability to detect those infants with late onset CCMV-related hearing loss, which would again allow for early intervention and identification. Additionally, although the majority of infants with congenital CMV will have no symptoms, it is the most common non-genetic cause of sensory neural hearing loss and has an incidence that's higher than the metabolic and endocrine disorders currently included in our core newborn screening panel. Cons are, again, we do not have direct evidence that valganciclovir is an effective treatment for asymptomatic infants with isolated hearing loss. And as Nita mentioned, valganciclovir has been associated with toxicities, including nephrotoxicity. Additionally, CCMV would be the first screening disorder of which most true positives are not clinically affected. If screening were to become universal, infrastructure would need to be established for both the collection and transport if using urine or saliva, and follow-up confirmatory testing would again present a challenge given the narrow diagnostic window of 21 days. So we just wanted to poll the audience, now that we reviewed the data again, based on this information, do you think universal congenital CMV screening should be implemented? And then we will give about 20 seconds for a response. And the answer choices are A, yes, no CMV screening should be done through hearing targeted screening, and no screening at all should be performed, and D, not sure or prefer not to respond. Okay, so interestingly, it looks like the most common answers were yes, 39% answered yes, and the most common answer was B, no, that CMV screening should be done through hearing targeted screening, with 2% responding no screening at all should be performed, and 5% responding not sure, prefer not to respond. So it looks like somewhat of an even spread between yes for universal screening, but more so for hearing targeted screening. Thank you for sharing your responses. And then just for some final takeaway points, again, the majority of infants with congenital CMV infection will be asymptomatic. However, hearing loss is the most common long-term sequelae of infection, and congenital CMV is the most common non-genetic cause of sensory neural hearing loss. Newborns with congenital CMV infection are at risk for hearing loss at birth, as well as for late onset hearing loss, and therefore warrant close audiologic follow-up, as well as confirmatory testing within 21 days of age, as after 21 days, we are unable to distinguish between congenital and postnatally acquired infection, and that does have an impact on treatment and management. And then lastly, additional studies are needed specifically regarding management of non-primary infection, particularly in pregnant women, treatment of asymptomatic infants, as well as prevention strategies, including vaccination. Thank you everyone for your time. We are happy to answer any questions you might have. You're also welcome to reach out to myself or Anita through email, which we've included in this last slide.
Thank you
Nicole,
both
there's one
for
question.
Go ahead.
Thank you, Ruth. I tried to answer questions as we were going through the presentation. Thank you, Alicia, for asking questions to help better define some of the terminology. One of the questions from Alicia, Nicole, is universal or targeted testing for congenital CMV more accurate in detection? Do you want to try to answer that just based on the last few slides that you have?
So I would say that in terms of accuracy of detection, universal does allow detection of infants with late onset hearing loss, as those infants who are CMV positive would be closely followed by audiology, and that hearing loss would be detected. Hearing targeted screening really only allows us to detect infants who have hearing loss at birth. Both infants would be tested the same way, I imagine, which would be either through saliva CMV testing or through urine CMV testing. So it really would be that universal screening would detect those infants with late onset hearing loss.
Thanks, Nicole. And then there's another question from Piedad asking, how much does, I think the question is asking, how much improvement would we expect to see with rehabilitation for a child with congenital CMV infection? Piedad, if I'm understanding your question correctly. I think the hope is that by identifying these children earlier and getting them into rehabilitation services, that we diminish the potential morbidity on their hearing and on their speech. Some of those children, though, however, do go on to require cochlear implants to facilitate their hearing. But with early recognition and referrals, the hope is to try to get them plugged in sooner before there's a significant impact on their speech.
I think that you did such a great job answering all of the questions while the session was going on. I think there's a lot of offline conversations happening. I want to thank both of you for just providing this update and great presentation on this topic. I want to give people maybe a few more minutes to add any additional questions that you have for the speakers while we have them, and so that they can answer them in today's session before we end.
Someone just asked a question about, is the labyrinthitis that is associated with hearing loss, does that also play a role in gross motor delay, which is a really interesting question and one that I don't know the exact answer to. I think that there's the potential that there's a vestibular impact from the labyrinthitis. However, most of the gross motor delay comes from direct CNS involvement, from CNS malformations and from the microcephaly that's been seen. There was one other very interesting and important question, which is, well, if congenital CMV has such implications for newborns, particularly mothers who are seronegative and may not even be aware that they are seronegative, why do we not universally recommend testing for all pregnant mothers to determine their whether they have had prior infection or not. And this has been the source of a lot of investigation and remains a question that I think we need additional data to support. There are several remaining questions that I think need to be answered before we can determine the utility of a universal testing approach for pregnant women. First and foremost, it's not clear, should we be testing everyone? Should we be, currently we test mothers who have a clinical suspicion based on development of a mononucleosis-like illness, or if there are prenatal abnormalities on imaging that suggest a congenital infection. We usually start with serologic studies in the mom to see if there is seroconversion, and then confirmatory testing with amniocentesis. However, if we were to choose a universal screening approach, unclear sort of when the testing would be done, how we would do tests, what testing modality would be used, and then more importantly, if you identify the women who are seronegative and seropositive, what do we do with that information? What we know about women who are seronegative who become pregnant, who develop infection, primary infection during pregnancy, is that there aren't very effective treatment strategies. Their antiviral treatment has been examined. Immunoglobulin therapy has also been examined, and none of them have really panned out as strategies that are very promising. So screening to sort of what purpose, I think, remains a big question that needs to be examined, along with what is the cost effectiveness of that approach.
Thanks for that, Nita. It seems like there was a follow-up information provided to the last question. I wonder if it'd be great to address it live as well.
So Nicole, would you like to take this one?
So the follow-up question that we have is, if a child starts late at treatment because he wasn't detected during his first year, for example, can he have some chance to improve his hearing significantly, even though the rehab started late? I think that would be an excellent question for our ENT doctors, but I think in general, ideally, we would start treatment as soon as we could in terms of rehab. It depends on the severity of his hearing loss as well. And I would imagine there would be some chance to improve his hearing, although again, it depends on the severity of his hearing loss, and also depends on what level of rehab he requires. Nita, do you have anything to add to that response?
Yeah, I think it's hard to say. It depends on, I agree with everything you said, Nicole. I think it depends on what degree of hearing morbidity is already present at that point in time. And then by treatment, I want to make sure I'm understanding treatment, if that's referring to antiviral treatment, that question has not been examined. The treatment typically needs to happen, in the very earliest parts of life, soon after the initial diagnosis. So that question of treatment, antiviral treatment much later, is completely unexamined. I think the relative benefit of treating that late relative to the risks of treatment probably make it unlikely that treatment would be something that would be recommended or feasible. But certainly, I think rehabilitation therapy is a benefit, and trying to capture children as soon as we can is the goal.
And it looks like we got another question. Will the children who are enrolled in those huge screening studies be followed over the years to see how many get cochlear implants and to see how their psychosocial development progresses? That is an excellent question. I have not, relatively speaking, so the data I reviewed has been over the past few years. So we do not yet know if those authors are planning to follow the babies that were found to have CMV related hearing loss. But that would be a really interesting question to see. And I do hope that they do follow them. I think we're just a little early yet in this question regarding these screening programs in these babies. But I'm hoping, 5 years down the line, 10 years down the line, that there are studies that do follow these babies to see what their psychosocial developmental progress will be and whether or not they did require cochlear implants.
I think many studies are limited by the feasibility and funding of longer term follow-up, but I agree with Dr. Wing. It is an area of needed further studies.
Okay, I am not seeing any more open questions right now. I know we're a little bit early than the usual, but I think there were great discussion, great questions already answered in the Q&A. And so I just want to wrap up the session by again thanking Drs. Srinivas and Dr. Wong for sharing your thoughts on this topic. I also want to thank our attendees for joining us very early on a Tuesday morning and participating in Children's Week. And just a reminder that we have an afternoon session just talking about pediatric cardiac arrhythmias. And then tomorrow we have 2 sessions taking place, one on the transition of care and also focusing on GERD. So we hope that you will join us for our subsequent sessions today, as well as for the rest of the week. And again, let me do a quick scan just to see if there are any other questions that came in while I was talking. And if there is, if you'd like to answer them, but I think there's some thank yous coming in there. So with that, we'll kind of wrap up. And again, just thank you. So have a great rest of your Tuesday, everyone. Bye.
Thank you all.